Hey, welcome back. This is Kathy from Synapse Care Solutions. It's our Monday live stream, and this week we have a replay from our 2021 conference in Orlando, Florida. It was just a few weeks before the world shut down, and it was so amazing to be together. And I know you're going to love this presentation from Suzanne, who is a nurse in the Family Nurture Intervention Program in New York. It is an amazing presentation for so many reasons, and I love how they have taken that science and that care and nurture and put it together. They have done randomized control trials that are going to blow your mind with the results, that how these practical things that we all do, but when put together in a program and done consistently, really make a difference. So if you'd like the slides for this presentation and some of the references, I'm going to go ahead and put the QR code back up here, and definitely go to the website of Columbia University, look for Dr. Welch's lab and the Family Nurture Intervention. You will be amazed with all the resources, more videos, and just more information about maybe how you can bring this practice to your NICU. So I would love to just say again, thank you for being here, for you being here, but also thank you to the participants of the 2021 conference that were there live and supported us when we were back doing in-person events. I'm glad that we're able to bring some of these presentations from our live events back to you because they are so special and can really still have an impact on the things we do every day. I want you to know about the different programs that are out there and the different research so that you can continue to improve the care for babies in your NICU, and especially the families. And as you'll see in this presentation, the nurses and administrators. This program gets at every single angle. So enjoy this presentation, and I'll see you at the end.
So the first 5 or so minutes, I'm going to start with story. I'm a storyteller, medical humanities. I am a nurture specialist. You may not be familiar with what a nurture specialist is, but by the end of this about hour, you will be. But I really identify as a NICU nurse. I am a NICU nurse, and what I find the story of NICU nurses is that is how they really identify. And how many NICU nurses are in the audience? Yeah. So I was a NICU nurse, and as I was and am, and as a NICU nurse, there are statistics that really startle me. And I'm sure you know them. 1 out of every 5 children, and this isn't NICU children, this is 1 out of every 5 children, will be diagnosed with emotional behavioral disorders and or developmental delay. And our NICU babies are at even higher risk. Our NICU parents, depending on which literature you're reading, 40 to 70% of them will come out of an ICU with an infant with signs of post-traumatic stress disorder, and really, most of them pretty significant. As a NICU nurse, that really disturbs me. But what really fuels my passion for this work is that my son, Zachary, is one of the 1 in 5 babies who came out of an ICU with emotional behavioral disorder and not severe, but developmental delay. It was supposed to be severe, but he's not. But and this is why the first 5 minutes of this presentation is hard for me, but I am one of the parents who came out with severe post-traumatic stress disorder. And so shortly after Zach came home, I went back into this environment and worked in it. And so it was so different, though. It was like my eyes were opened, and I saw all of these things that I never saw before. And it took years, and I raised my children, and I went back to school. Not the traditional route. I have a master's in holistics, and we're still working on this doctorate in medical humanities, because I wanted to tell the story about what I was seeing, these huge gaps in care that I was seeing in the NICU. And so I worked as a March of Dimes family support specialist for a while. I was really proud of that work. And I had gone to the Gravens conference and saw Dr. Michael Myers speak on the Nurture Science program at Columbia University. And a few months later, I was working in Newark at Children's Hospital, and I saw Dr. Welch, Dr. Martha Welch of the subway story they talked about. I saw her washing her hands and I made a beeline to her. And by the end of this presentation, you're going to understand why this is significant. But I grabbed her hands and I looked right in her eyes and I said, Dr. Welch, do you know how important your work is? And she kind of laughed. Yes, I know how important my work is. But tell me why do you know how important it is? And so I told her my story, and I've been working with her ever since, and I'm really proud to be working with her. So these are my learning objectives. We're going to learn about the theoretical underpinnings. We're going to look at RCT results, and then I want you to go home with some actionable items, things you can do. No financial conflicts. And this is Dr. Welch in an introduction to our program.
So the urgent need is to find, first of all, a prevention, and secondly, an intervention.
Like, I was here for 7 days. I came minimally. I was also in a lot of pain from the C-section and the drugs. Like, I would just wake up to pump and then just like want to lay back down, deliver the little Q-tip amount full of milk that I could have given him, and I just went back to lay down. But it was more physical. Like, I looked at him in a more physical, you're tiny, like, it wasn't like, oh, my baby, like, I didn't have that.
The good news is that family nurture intervention is a remedy for interrupters.
And so our mission is to develop, test, and scale evidence-based interventions to help families overcome emotional, behavioral disorders, and optimize brain development. And what we found was through our program, it became a neuroprotective program. And it's not necessarily what it was initially set out to do. We initially were looking at length of stay studies, but our results led the way. So from 2008 to 2012, there was a randomized control trial of 150 infants, half of them in standard care and the other group in family nurture intervention. The gestational age was from 26 to 34 weeks, and the average dose, and the dose was time spent with a nurture specialist, was about 3.5 sessions a week. The cohort has, it says here, follow up to age 5. They're well past stage 5 now, still being followed up. And so these are the published outcomes of our study. There were other outcomes, and as they can be improved, but they're looking for statistical significance. These were all significant. So at 36 weeks, our moms had better caregiving behavior. And what we did was serial videos, and we have equipment called NOLDIS, and it's coded frame by frame. So our moms had more fluid caregiving. At 40 weeks, we looked at serial EEGs, and we're going to talk about this a little more in a minute, but we did EEGs at 34 weeks and then again at 40. And what we found in our intervention group was that our babies' brains were looking like the brains of babies in Maine nursery who were born full term. And that was really extraordinary. We're going to talk about that a little more. At 4 months, moms were less depressed, less anxious on the SESD and the STI. And we wondered, okay, so we're seeing all this. What's going to happen when we get to follow-up? At 18 months, our Baileys, we had improved language and cognition. So we were so thrilled that this was following our babies. Less attention problems on the CBCL. And a decrease of positive screeners on MCHAT. So MCHAT is the screening for autism, if you're not familiar. And this was the Sentinel article that talked about how 26% of preterm infants were scoring nationally for risk for autism. Now, if you screen positive on the MCHAT, it does not mean you're autistic. But what it does mean is that these kids learn a little different. They react to their environment a little bit different. But what we found in F&I was that our kids were much lower on those screens. This is a slide that shows our EEG. We have 124 lead EEG. And again, what we saw was this increase in frontal power, which is where executive functioning is. It's what makes you who you are. So we had marked increase. For our moms, again, that trajectory, the caregiving, the decrease in depressive symptoms, and out to 5 years, we had better vagal tone. And so I'm going to ask you, how do we measure emotional connection? And this is something that we're really interested in at the Nurture Science program, not just in NICU, but really universally, looking at connectivity. With mom and baby, we're really looking to see attraction, vocal communication, facial expressiveness, and responsiveness and reciprocity. Again, if the baby's crying, that's okay, but mom's reaction kind of matching that, and this reciprocity going back and forth. So we're creating a tool called the Welch Emotional Connection Scale. It's validated in 4 months right now, but we're working on a scale for NICU currently, and we will be looking at those 4 domains. So this is what I want you to recognize. Our standard care mom, her baby was born at 28 weeks. So if you look at the power of that baby's brain, and this is actual, it was down somewhere, it's hard to say, but about 1,700. And if you look at our 32-weeker, who is our, I'm sorry, I meant F&I, now the standard care mom is a 32-weeker, that 34-week brain power was way up there at 36, 37. But when we did the EEG at 40 weeks, look at the jump in our 28-weeker. And what we found was that was really the level where full-term babies were. But our 32-weeker declined. And so these aren't the only 2 patients we saw this in. We saw this pretty standardly. And so we really wanted to look at what was it that we were doing that was making this difference. And the next piece of my presentation is going to talk to you about what it is that we really feel we did. And so this photograph, incidentally, was taken by my son, Zach, who is now a college art student in his photography class. And what we decided to do was to do a dissemination effectiveness trial over in New Jersey, thus the bridge. In a level 3 NICU, where I was a nurse for many years, and we have about 18 to 25 beds. So it was scalable. We would be able to really educate the staff. We would also, it would be manageable. And we're going to talk about what the nurture specialist does as the calming cycle. And I'll tell you why we call it the calming cycle, because we believe the effect is not only from emotional connection, and you'll see to the right the emotional connection, but on the left, autonomic co-regulation, which is something that I'm really fascinated by. Autonomic co-regulation and conditioning. So I always use this example when I'm teaching the nurses about it, of when I first get up in front of an audience, my heart rate's a little high and that respiratory rate's going. And after 5 minutes, I regulate. As long as you have an audience that's receptive. You're here in this audience of like-minded people who all want to make a difference. It's really easy. All of a sudden, your heart rate just sinks. That's what happens to our babies and our moms. That mom is all tense in the chair, not knowing, is me taking the baby out a good thing or a bad thing? Am I hurting my baby? The baby is used to that procedural touch. But once you get baby and mom together, and it doesn't just have to be in kangaroo, we're going to talk a little about that, but once you get them together, both of their physiological systems sync and regulate, and we have seen that. And it's a conditioning response. And so this is what we call the calming cycle curve. And this is a tool I use for parents and the nurses primarily, and the docs. Because think about it, you have these really unstable babies, and they say, I'm not really sure about taking this baby out. I don't know if it's a great idea. He's had a few Brady's today. It's not great. And what we say as nurture specialists, and we build these beautiful relationships with our clinicians, let me just give it a try. But what we share with them is the first time, and we all know this, the first time you do it, it may not be so great. It may not go perfectly. But what I do know is if you throw that baby back in the isolette and you tell the mom, oh, it didn't go well, we were not going to do this for a while again, it's not going to benefit anyone because we know the next time, and this is actual from our original study, each time we take that baby out for a calming session, it takes less time for that baby and mom to calm. And their stress level is less each time, almost to the point, and you know this, almost to the point where it's just fluid. And we can say, okay, well, the baby's getting better, but it's not always just that the baby's getting better, it's that they're getting better at being together. You can play.
My name is Mary Kay Mendoza. My daughter's name is Arlene Lazaro. She was born at 27 weeks.
My name is Susan Muccio, and my daughter's name is Amelia, and she was born at 29 weeks.
My name is Agatha Palco. My son, Peyton Preston Palco, was born December 16, 2017. He was born at 26 weeks.
I didn't know what to expect. I didn't know what was going to happen. So when I went to go see her, it is when you see her for the first time with all the cables attached, the CPAP on, she didn't even have enough energy to move around. I felt like there was nothing that I could do to help her because I didn't know what she needed.
I didn't see her for the first at least 4 or 5 days, so I was non-existent as opposed to I got to see the other two right away. And yeah, so it was a little sad. I was very sad, actually. I want to see my baby, I want to hold her, and then you don't get to feed her, and then you could only hold her for a certain amount of time.
I think at first it was just so intimidating. What can we do? What can't we do? What's appropriate? What's not appropriate? Is it okay if I bring my mom in to come see them? Is it not? If she does come in, how long should we stay? Are we in the nurse's way? And then that balance of wanting to be there, but also wanting to give them space to do the work they need to do, especially in those first couple days when they were so small and so sick, just not knowing kind of how to find that balance of giving the staff their space to get their work done, but also letting the boys know we're here, I'm your mom and I love you, and being there for them at the same time. It was hard to find that balance in the beginning.
It was definitely not what I expected. And yeah, and now I was afraid to love my child for a really long time. And I think it was still, even when he came home, it was hard.
I know some of that is hard to see, but that's what our program is about, is really looking at the things that can be hard. So this is a longitudinal view of some of the lasting effects of emotional disconnection. So it starts with this fear. So what did you hear from our last mom? The overarching theme was fear. And you cannot live in perpetual fear. And that is often why you'll see those parents who don't show up. That's the reason. So it turns into apathy, and then apathy can turn into avoidance, and avoidance is a disconnector all across society. So what are the biggest avoidance devices we have? Our telephones, technology. It's great, but it also sets us up for disconnection. And then if you look into the future, we know the divorce rates of NICU parents are very high. And these are things that happen down the road that we may not be thinking about while we're in NICU. The absence of emotional connection impacts the entire family's well-being. And I know that sounds really grim, but I'm going to mimic Dr. Welch and say, but there is good news, because what we found was that family nurture intervention worked like an umbrella to shield our families, moms and babies, and we didn't study them, but dads and siblings too, grandparents, protecting against the stress that NICU causes. We cannot stop all the stress in NICU. We cannot stop the necessary separation, the necessary medical procedures, but what we can do is really shield them. And so you'll see in this picture, what is the number one separator in the NICU? Anybody want to? The isolette, this plastic device, and one of our nurture specialists says devices are divisive. This isolette has great purpose, but that mom doesn't know that she could actually open up that door. And when we teach her these kinds of things, this disconnect can go to connection. And this is when we took baby out. But there's a lot that happened in between that separation and this physiologic state of autonomic co-regulation and connection, and that's what I'm going to talk about next. And so these are the activities of our calming cycle. This is what we do. And what we hear is, but we do this. We've heard all this. We do holding, touching, kangaroo care. We do eye contact and smelling and yada. But what makes it different in family nurture intervention is that in that inner circle, there is emotional expression. It is pivotal for our families to be able to emotionally express what they're going through, and there is no one better to talk to than your baby. And that is really what we feel is our key ingredient. Also, consistency. So you may do some of these things some of the time, but on this consistent basis, we're seeing results. So, holding, touching, going back to the devices, we set up our moms with all these pillows because we want them comfortable. They have the comfy chair, all these pillows, and one of the nurture specialists, Erica, says, Mom was holding a pillow that happened to have a baby on it. When they're holding their babies, make sure there's skin contact, even preferably, we all know, skin to skin, but as much skin as possible. But even if they're clothed holding, encourage them to hold the hands, look in the eyes. And I can't say enough about interactions in the isolette. There's a huge difference, and I don't have it here, but a huge difference between the mom who sits feet away from the isolette, then the mom who we bring the isolette down to mom's level, and mom opens the door and gently speaks to the baby, and what the baby does is he or she rivets right to mom's eyes. We see it over and over again. So there is the eye contact, and it follows them. We can see that mom and dad who make that consistent eye contact in NICU, that follows in the follow-up, we see it. Smelling, the previous talk did a beautiful job illustrating smelling, and that subway story was from our study. But what I want to say about the scent cloths is often I'll come into the NICU, I'd find them at the end of the isolette. We want them up. Our mom's scent cloths that she wore in her bra that she got her breast milk on, we want them up where the baby can smell them under their head. And we want to show mom how to use this scent cloth, and we even do a visual where mom wipes it on the baby. So when she goes home and smells it, she has that visual of this was on my baby's body. Singing, talking, crying, and listening. I'm going to show some videos that are going to illustrate this, but this is really the crux of emotional expression. And so this is an audio of one of our moms who did not have family nurture intervention.
I was trying not to be sad whenever I would see her because I didn't want to transfer any sadness. That's another part of it. And what did that feel like for you to have to block that? The sadness? It's like you're holding your breath. You're holding your breath and you're trying to keep it together so that Ellie doesn't feel any sort of sadness, but then it's almost like a barrier that you're putting up.
And so those words, I didn't want to feel any of the sadness, but it was like holding my breath, like a barrier I was putting up. The prompt here for mom was, what was stressful for you in NICU? with no knowledge of what we were doing. And so I think the question we always want to ask ourselves is, do we really want our parents to get to that emotional place? But they need to. They really need to. I'm just going to set this up for a minute. Mom here had a twin birth. One of the babies did not make it to the NICU. And it took a long time for her to be able to accept her baby's death. And once she was able to express about it to his sibling, she was able to then recover his body from the morgue and actually bury him. So we'll play that.
Daddy and I used to fight all the time because I said that you would look like me. And Daddy would say that you would look like him, but you're so tiny and I already think you look like me. Your feet, your hands, all that hair on your body. You're so cute. I love you so much. Looking at you makes me happy. And it makes me think of Caleb as well. Even though I miss him, I named you Noah Caleb because I wanted you to always carry his name. And I promise to love you for the rest of my life. I promise to love you for the rest of my life, and will always remember your brother. He'll be our little angel, watching all three of us, Daddy, Mommy, and you.
And so our tendency sometimes when our parents go to these places is to give them tissues and tell them it's going to be all right. And it is going to be all right, but they need to express it first before they can get to that place. The difficulty is, and we're going to talk about this a little later, is when the staff are trying to save the lives of these children, there's always that issue of time to be able to sit and do this. And so the nurture specialist is there to act as that catalyst, but we don't do it for the staff. We help mom through, and then at pivotal moments, we bring the staff in because it's really, and we're going to talk about this later, it's really important because that's the part of the job you all love, being there for them, part of it. So just quickly, we're going to look at this mom talk about what it was like learning to emotionally express.
Slowly, it's gotten easier, just coming into being into a routine with him, holding him every day, talking to him like about normal things that if I was home, I'd talk to him about, you know. But in the beginning, it was hard talking to him because I didn't know if it was weird of what I was saying. Should I be talking to him like this? You know, can I tell him things that I'm scared about? But the more I did that, the more comfortable I felt and the more close I felt to him. Like I could talk to him about anything.
Yeah. And so once they get the hang of it, and we have audio journals, and you could do it on an iPhone, do an audio journal, but direct it at the baby, talk to your baby. And we have different prompts we use. Then the last piece is family support, and that wasn't always in our circle, but it was really important to me because of my background to include family support, but it's different than what you may know as family support. And in no way do I belittle the wonderful things they do in family support, holiday celebrations and things of that nature. But in nurture science, family support is geared toward teaching the extended family about emotional connection and its importance and gathering support for mom because she needs those connections. And our next slide is going to set up to show you why that's important.
This life-changing thing that happened to my family was such an awakening and such an eye-opener because it showed me who was really there and who like my friends were. And for a long time, the NICU was my family and the nurses were like the ones I would go to for everything before, you know. And then thank God, like I had the moms like Nidhi and Ashley and Heather, like they're still my rocks till this day. But yeah, I got into so many arguments with family members and I actually ended friendships because when you go through something like this, it's not, you don't ignore it. You know, I know they might not have the right words to say, but an emoji or something would have been great to hear from friends. I didn't have that. So it definitely helped me see who was like real.
And a few things she said really stand out to me. One was that, the NICU nurses became her best friends. And we see that repeatedly. And it is so wonderful and so important. But we can't take the place of grandma and auntie and your best friend that you've had since you were 4 years old. We have to bring them in. They need all of us. Our moms and dads, they need all of us. We're not a replacement, we're an extension. And so one of the tools we use is called the Mom Support Circle. And we look at everyone in her circle. She tells us all about her circle. And we have mom rate them from 1 to 5 on availability and helpfulness. And that helps us really be able to get at who we should be bringing in. So I'm going to talk a little bit about how we went about getting buy-in in this dissemination trial where we rolled out family nurture intervention, not like in the RCT, where it was some babies got it, some didn't. This was every baby got it. We didn't study all of our babies, of course, because we need consent and there's different criteria, but every baby received family nurture intervention. And so we needed buy-in. So we went to all of our stakeholders. Paul Hawkins said, all is connected. No one thing can change by itself. We all know that's true. But all of our stakeholders value things a little differently. And so what our Patient Family Advisory Council valued, and our staff valued, and our administrators valued, and what our foundation, and we really wanted to loop in the foundation because we know we need financial support for this, they all valued different things. So we had to figure that out. But I'm going to concentrate for a minute on nursing because we have a separate study where we're looking at a mixed methodology of studying nurses' experiences before and after family nurture care. So
I'm hoping through Nurture Science and the Nurture Science program that we're going to allow ourselves to get back to the bedside, get back to patient care, relating to our families, instead of using the technology and distancing ourselves. Use that to get things done, but be able to connect with our patients and help our patients to connect to their families. I'm hoping.
I love working with the baby and the family, honestly. I didn't know that when I worked nights for so long because, you just trudge through the night shift and get through. But when I came to days, I found out how much I love seeing mom and baby connect.
So we asked all of our nurses, and we had 76 in our study. We asked them what they value before we ever started family nurture intervention, and they were not sure what we were going to be doing. They thought they knew, but they weren't sure. And they valued being at the bedside with the family. That was the thing they loved about their job the most. But we also did ethnographic field notes. For 18 months, our research team went around and took notes on what everyone was spending their time doing. And that was the thing they were able to do the least. And so when you think about that, that's what you value the most, but what you can do the least, it's a setup for burnout, which is a big buzzword now, and moral distress. And so we wanted to study that. We did our 4-hour training in between our control phase and our intervention phase. Right here, you see our nurses with a task list of 12 tasks, some of them like suctioning and putting in an IV. But we also had things like supporting mom emotionally and taking baby out to kangaroo. We had rounding with the doctors, different things. And so we did a beat the clock, and they had to put them in order of priority. But then we changed things up and said, but the doctor is saying he needs you right now. And then where does it go? And inevitably, those things that we do in family nurture care kept sliding down. And so it was a real eye-opener for them. Post-training, this is what administration thought.
My aha moment was my most senior nurses who came back and were like wowed because they looked at their practice in a totally different way. And to see them take it on in a new focus rather than just the science of it and the skills and the tasks, they're great at it. They can do it backwards. But the fact that this was a new way to look at it, and it was almost an excitement that was generated over there that I did not anticipate at all. And people are now becoming more involved and more vested in it because they're excited by it. And that I didn't anticipate, and I appreciate that that happened because it's definitely elevated the level of interest and excitement in the practice.
And so interestingly enough, most people were really excited to bring family nurture intervention to our unit. This is our director, and he actually really wasn't. So he's converted. This is our social
I
worker.
have seen a change in the staff since the nurture training, because I think where staff in the past were very nervous to either take babies out or really, err on the side of caution where the baby might not be having a good day or might be having some like desaturation and stuff. I think I've seen the staff become more open-minded to let's try it. Let's see if the baby can come out and mom can hold. And I've had feedback from moms where they've said they didn't think they'd be able to hold the baby. And as soon as they held the baby, that skin to skin, and once the baby was on them, the baby actually improved. And I think that just reinforces for the parents too, the emotional connection that you are the mother still, and it is important for you to be able to hold the baby. And I think the staff has come a long way. Yeah.
And so in our study, which is just about wrapping up, and so we don't have all of our results, we were looking at burnout, empathic response, teamwork, and work engagement. So we have our qualitative data, which will continue being analyzed. The quantitative data we just started looking at, and we have very preliminary results, which I'm going to share with you on one of our measures. But first, I really want you to watch this video of one of our nurses, which really talks about what we saw in the first result.
I learned a lot from the training, by the way. So I'm fairly new to the NICU because I've only been there 2 years, which seems okay amount of time, but compared to these seasoned nurses who've been there for longer than my life, I consider myself still newer. And I always knew it was important for mom and for the babies to bond, but it wasn't my main focus. Like, I'm like a systems girl, head to toe. I need to this needs to be good going down the line. And I never incorporated that as part of it. So what I took from that is the importance of making sure that bonding is there, because I had no idea and I sound really naive, but I had no idea up until listening to the videos and the education component, how much that really affects them later on. I never thought of that. Like in the NICU, I think what's important right now, but it made me open my eyes as to it's not just the work we do here, it's what you're setting up for them to have a good quality of life later on. So maybe I thought about it, but it never played such an important role as to me seeing it, the videos. And I'm thinking what can I do now so that this doesn't happen kind of thing. So it really just opened my eyes in that aspect. And then I'm more focused on, okay, I have to do this for baby. And then there's less time for, and I don't want to say this is not important, but there's less time for okay, I don't have time to take this baby out. I don't have time to do the skin to skin. And I don't want to be that nurse that doesn't take the baby out and make sure and allows bonding to be a big component of what I do for the day. But unfortunately, that's what gets sacrificed when you don't have enough time. You're just okay, let me just do this feeding, this baby's stable, or just try to get the baby stable. When I have days that I'm running around crazy and I felt like I'm jumping around from place to place, I don't feel satisfied at the end of the day that this was a good shift, right? I look back and I'm oh, I could have done this better. Or if I wasn't so busy doing this, I could have seen this, or I could have foreshadowed this happening. So when things like that happen, it makes me I'm one of those nurses that I go home and I think about things all day, what I could have done better, obviously, because I want to make it a learning experience for the future. It makes me strive to be a better nurse, but then I feel disappointed that I wasn't the nurse I wanted to be that day. So it's hard. So the collaboration with the nurse specialist has been a positive one. When I see you guys there, I feel as though if I'm having a busy day and maybe I'm lacking in this part of my ability to be the best nurse that I can be in this emotional aspect, I feel the support from you guys that you guys are going to come in and fill that part for me. So I feel it's a big team. I feel it's a big team approach. And I feel it's one of those, if you have my back kind of thing. I feel, oh, I can't do this, but I know they have my back and they're going to come in and they're going to swoop in areas I know I can't do today kind of thing. So it's been, you're going to make me cry, Suzanne. Jeez.
And so we've been able, this is again preliminary, but we've been able to move the bar with statistical significance on emotional exhaustion in the MBI. And so I believe that part of that is what Maria spoke to, that it's emotionally exhausting to want to do something and not be able to. And so again, we don't take the place for them. We pull them in. That's a whole nother talk about how we pull them in and what we do for our nurses. To flip back to the administrators, so that's what nurses value, but what do our administrators value? Our administrators are valuing that length of stay, those quality indicators. And so in addition to the research and the EEGs and the nurse study, we also looked at our quality indicators. And what we found was in our youngest babies, our 24 to 29 weekers, if you want to look at length of stay, we changed length of stay from 100 days to 84 days. And that was really significant. We also lowered days on respiratory support, days to first breastfeed, days to first skin to skin. In our next group, 32 to 34 weeks, what's the main concern in this group? It's weight gain. So if you look at weight gain velocity, grams per day, it went from 8.9 to 14.5, and we're really proud of that. In our over 34 weekers, we didn't see change significantly, but nothing was worse. So what that establishes is that it's very safe for our late preterm and our full-term babies. So that was really great. I'm going to leave you with some parent testimonials.
We think that family nurture intervention's effect is from emotional connection. The goal is to help the field and indeed parents understand nurture, why it's so vital, how it is a prevention as well as a treatment.
I wouldn't know what to do if you guys weren't here. Just everything, helping me connect to him. I'm gonna start crying.
We like that.
Just being there for me.
It's okay to feel it. That's what this is. Being able to feel what you're going through and breathe through it and get through it.
Always checking in, advocating for us when she was still 2, just so that I could touch her and hold her. Getting me to make connections with family that I never even thought of. It's amazing what you guys do. Just being a support that I guess we never knew we needed, and then you guys were just like right there every step of the way, so it's been amazing.
I feel like mothers everywhere, not just in the US, but in the whole world, should have this kind of support because every family is different. And in my case, I was here alone in this state. I have family in another state, but in this state, I was alone. So it's a good support for the mother because other people being there for her, telling her that everything's going to be okay, reassuring her that every little bit helps, gives you hope that everything will be okay in the end. And it's also very important for the babies because, like I said, mothers sometimes they don't know how they can help their baby, even if they want to help their child. They might not exactly know how to help them. So if they knew how to help their babies, I think babies would develop better.
So I think it's really important for moms to have this extra hand in the nurture study in the NICU because nobody is ever prepared for a NICU experience and you have no idea what you're walking into. And I know everybody's case is different, but with that extra help, like you just feel like you're always okay. Like they're gonna be there every day. They say, oh, I came earlier, she's doing A, B, and C. You just get a sense of security. Like you feel like, okay, we could do this.
I think part of what was so special about the program is that it made me realize that it wasn't just me being able to help Arlene, but Arlene was also helping me, not only emotionally, but also like mentally and even physically, because every day I would get up and knowing that I would be able to go and see her.
I actually got to bond with my baby in a very difficult situation. think that every single mom and dad should have access to this kind of support.
So I want to thank our team back at the Nurture Science Lab in New York and our affiliates in Texas and Connecticut and New Jersey. And I want to thank all of you because we're so grateful for everything you do for babies, families, and our staff. This is where I cry. I'm a crier too. Thank you.
Wow, I don't know about you, but that presentation always gets me. It is so amazing how they took this program, these ideas, these things that we do, and they've really amplified their focus. This idea that emotional connection is really what we're getting at. It's not just the things that the parents do. It's not just those interactions like reading or singing or talking, but it's really about developing emotional connection, not just bonding, but true connection that we can see from their study last for years and years to come. I hope you've been inspired by this group and by this work, and that you will definitely go to their website and check out all of their resources. If you'd like to download some of the resources, the slides, and links to their website, just click the QR code or in the show notes below, and you can get connected. Our next live stream is going to be about delivery room cuddles with Dr. Paul Clark. So I'm excited to bring that presentation back to you from a previous community call that we had back in 2021, I believe. And it is something that I think you're going to find to be special and can really change the things you're doing in your nursery. So I hope to see you next week for another live stream. This is Kathy Randall. Thank you.